So Stephen's my name, and first of all, thanks to Dara for the invite to present here today. So I'm a consultant radiologist with a special interest in interventional radiology, and I predominantly work in Cork University Hospital, but I also work with Dr. Brady in the National HHT Centre, predominantly in performing pulmonary arteriovenous malformation embolization, which some of you may or may not have experience in undergoing or have family members who have undergone this procedure. So I suppose just a little bit of background on myself. Any interventional radiologist usually trains in radiology first. So I initially actually trained in pharmacy and then went back to medicine. And after a few years of as a junior doctor, I did my radiology training between Cork University Hospital and the Mercy University Hospital. And then I suppose after that, I moved to Canada with my wife for 2 years. And I suppose that's where I got a lot of my exposure to pulmonary arteriovenous malformation embolization. Following that, I kind of changed tacks a little bit, and I did sports imaging and musculoskeletal imaging between 2019 and 2020. And then during that time, I spent 1 or 2 days a week in Sick Kids, which was a big children's hospital in downtown Toronto that would have dealt with a lot of rare disorders. So we would have seen a lot of pediatric patients coming through there. Obviously, not a lot of pediatric patients undergo PAVM embolization, but there's still a lot of care, obviously, that goes with that. So just, I suppose, specifically in relation to my experience in HHT and PAVMs, as you heard, Dr. Brady leads the National HHT Centre with his wife in Cork. So I suppose during my time training in the Mercy, I would have had a reasonable exposure to PAVM embolization. Obviously, Ireland as a country isn't huge, so our population isn't huge, and our incidence of HHT isn't huge. So I suppose the frequency of procedures in the Mercy, I mean, we done a lot of procedures, but the frequency, it's not like a daily or a weekly procedure. It's more a procedure that we'd be carrying out, say, on a monthly basis there. Whereas when I moved to Toronto, St. Michael's Hospital would be part of the HHT network, and Dr. Marie Fawnin, who works there, would be, I suppose, one of the leading international researchers in HHT. So we would have had a lot of referrals from all around Canada. So we would have been doing maybe 1 or 2 PAVM embolizations every week. So kind of build up a lot of, most of these procedures, as I said, they're not a procedure that we would do every day, but a lot of the other procedures that we do every day are quite related to this type of embolization. So as interventional radiologists, we would have a lot of exposure to these procedures. And as you know, Dr. Brady does nearly all the PAVM embolizations in the Mercy, and then this is Dr. Prabhudesai, who does most of the PAVM embolizations in Toronto. So I'm not going to speak too much about the National HHT Centre, because I suppose my involvement is really just in carrying out the PAVM embolizations, and Dr. Brady and his wife do more of the organizational and structural approach in the development of the clinic. I suppose it's been operational since January 2003, and overall we estimate that there's probably between 500 to 1,000 affected patients in Ireland. And I suppose because HHT is a rare disorder, HHT patients may interact with doctors who may not be aware of the condition, because most of us won't be exposed to it during our working careers. So many patients will actually go undiagnosed. In Cork, the National HHT Centre has screened over 700 patients since its inception, and we've experience of embolizing 202 PAVMs during 107 procedures in 65 patients. So as you know, many patients will have more than one PAVM. Many patients will need more than one embolization procedure in order to treat the PAVMs, and in some cases, the PAVMs can recur, so they may need a subsequent procedure. I suppose one thing that I just wanted to touch on in relation to HHT is, I suppose, obviously, most people attending here today have more experience in the healthcare management of HHT and their experience of healthcare, but it is obviously a complex multi-system disorder, and with that comes lots of different specialities who may have interests in particular niche areas. So, I learned a lot from Kira and Neve today in their discussions, and obviously there's lots of areas of HHT that I have very little knowledge about. And it really takes a multi-spectrum approach or multidisciplinary approach to truly treat a patient with the HHT. So, I suppose in terms of like the most common types of symptomatic presentations that patients can get that need presentation to hospital or to GP or to dentistry would be epistaxis. So we know that if we took 100 patients with HHT, 90% of them will be symptomatic with nosebleeds at some point in their life. In terms of the PAVMs, Now, it depends what studies you read, because any of these studies won't have hundreds of thousands of patients. So you might read one study that says 10% of patients have a PAVM, and another study will say 40 to 50% have a PAVM, and that might depend on their screening or how frequently they screen somebody for the disorder. But we know that approximately 30% of patients will have a pulmonary AVM. We know that approximately 10% will have a brain AVM. Up to 90% of patients can have telangiectasia in their GI tract, but only 20% will be symptomatic of those. So despite the fact they're there, lots of patients won't ever know they're there or won't ever have complications or symptoms associated with them. And we know that approximately 70–80% of patients have arteriovenous malformations in their liver, but again, only 5% might become symptomatic of those AVMs. We know overall that because of all these different types of multi-system problems, that 10% of HHT patients can die prematurely or suffer major disability. And obviously, things like the HHT network and collaboration between different physicians is obviously trying to increase awareness, so to try to decrease the morbidity that's associated with having HHT and make sure that patients get the correct treatment at the correct time. So I suppose from here on, what I'll talk about is, I suppose, my area of expertise, which would be radiology and interventional radiology. And I suppose the two things that radiology does really is imaging and intervention. So I suppose in order to treat something, we need to know that it's there. And we know that these types of problems don't happen in all patients. So a lot of patients will start off with an echocardiogram of their hearts, a contrast enhanced echocardiogram to assess if there's evidence that there might be a pulmonary arteriovenous malformation. And if that echocardiogram is positive, they'll often go on to have a CT scan. So you can see here, this is the left lung, which is a normal appearing left lung. And then in the right lung, you can see this very abnormal area down here, which is basically a PAVM at the lateral aspect of the right lower lobe, and then a feeding artery and a draining vein coming back to the heart. So that's what a PAVM looks like on a CT scan. This is a patient's CT scan of their abdomen, and this structure here is the liver. Just to check, are you able to see my mouse?
Actually, I was going to interrupt there, Dr. Stephen. Okay. We're seeing the presenter view. So we're seeing the current on the next slide. If you could just swap them around there in the display.
Oh, yeah, that's no problem. I'll just stop sharing there for 1 second, and I'll share the opposite screen. That's okay. Right. Sorry about that. That's probably the better one to share. Can you see the presenter screen now?
No, we have the right screen now. That's great. Thanks.
Okay, that's perfect. So sorry about that. So this is a patient CT scan of their abdomen. So all of these small little dots that are within the liver are basically all small hepatic AVMs. And then this is an MRI scan of a patient's brain. The right side of the brain is normal. The left side that has all these dark areas of abnormality, that's a brain AVM. So obviously, one of the most important parts of treatment is identifying that a problem is there, because if we don't know it's there, we can't counsel the patient regarding the risk or treatment options. So imaging and the interpretation of imaging is one of the key roles of a radiologist in, I suppose, the management of HHT. And then I suppose the other area of that radiologists or interventional radiologists are involved in is regarding intervention. So embolization is something that's been around for about the last 30 years, and it's basically blocking off the blood supply to abnormal areas of vascularity. So there's lots of different indications for performing embolization. So despite the fact that we may not see a HHT patient every day, we probably see patients for embolization, once or twice every week. So the experience that we gain in those types of embolization procedures is what we use to treat patients, rarer patients who present with HHT who need embolization. So nosebleeds, I suppose, typically can be managed conservatively, and most patients with HHT or without will never need embolization for nosebleeds. But in very rare situations, patients can need that. This is an image just here is basically a catheter that's been inserted into the patient's body, and we're injecting contrast dye. And this is the blood vessel that's coming out to the patient's nose. And then we have all of these areas of abnormal hypervascularity within the nose. After embolization, you can see this. The hypervascular areas demonstrated by the white arrows here are all gone. The catheter is still there, and the main blood vessel that's coming out to the nose is still patent. So you still have blood supply to the nose, but the abnormal blood supply has been reduced. And similarly, for a patient who has a PAVM, this is a catheter, and that's again injecting X-ray dye into an abnormal feeding vessel into a PAVM, and this is the blood vessel that's coming back to the heart. So this is the abnormal PAVM. And then this is after we've inserted a small number of coils into that abnormal blood vessel. And you can see that there's now the blood that was previously coming back to the heart on this study isn't present anymore. So we've blocked off the abnormal blood supply, and the blood that's coming to the lungs is then just going to normal areas of lung. So as I said, in relation to PAVMs, we know that 80 to 90% of PAVMs are associated with hereditary hemorrhagic telangiectasia. So it's very rare to see a PAVM outside a HHT centre. So we report CT scans every day. I'd say in CUH, which would be a large hospital, I haven't seen a PAVM in the last year. Whereas in the Mercy, because there's a screening centre, it's much more like you're much more likely to see them. But I know that if I see a PAVM on a CT scan, that the high likelihood is that person has HHT. So I suppose one thing is about identifying the PAVM, but it may also be about advising the referring physician that there's a likelihood that this person has an underlying HHT, and they should probably be screened for have the HHT screening pathway. And as I said, we know that up to 30% of HHT patients have PAVMs. Typically, they can be stable in size, but they can increase, particularly in adolescence. So as a child goes from a teenager into adulthood, or also during pregnancy because of changes in hormonal and vascular factors. In terms of what symptoms can patients get with a PAVM. So if you look at a normal, so this is what a normal, in any part of our body really, but I suppose in relation to the lung, this is what a normal vein to arterial network looks like. So what happens is the blood comes back from the body that has all the oxygen has been used up because it's been used in all the different cells in our body. It then comes into the capillary network. The air that's within the lungs then allows the oxygen to diffuse into the capillary, and then the blood that's coming back from the lungs has all the fresh oxygen that's been taken up within the lungs. However, if you have a PAVM, what happens is the blood comes back from the body, it shoots straight through this AVM, and then it goes back out to the body. So the normal oxygenation doesn't happen. So you can imagine if you have a small AVM, that might not be a big deal because most of the blood is still going to go into these normal capillaries. But if you had very large AVMs or multiple large AVMs, then a significant portion of the blood that's coming back to your heart will go through the lungs without getting oxygenated normally. So that means that some patients can have breathlessness or decreased oxygen saturations. The capillaries actually act almost like a filter. So you can imagine, if any bacteria or if any small little blood clots or little fragments of blood or bacteria come through a normal network, they'll usually get caught up in this capillary network and won't be able to transition back to the body. But somebody with a PAVM, any small clots or bacteria can travel through these AVMs, head back out to the body, and then can cause, infections. And that's why, as Kira was talking about, the importance of having antibiotic prophylaxis for patients that are presenting with known PAVMs. Those PAVMs can also cause migraines. They can also cause hemoptysis. And I suppose the reason that we treat PAVMs, what we want to present is patients having strokes. So when I look at a CT scan before I treat a patient, what I want to know is the PAVM simple or complex? And if it's simple, which 90% of PAVMs are, that's I suppose it's kind of encouraging prior to a procedure because it makes the procedure more straightforward. So basically a simple PAVM has one blood vessel coming into it and one blood vessel coming out of it. So I know that I need to block off just one vessel to completely treat the PAVM. A complex PAVM has more than one blood vessel coming into it. So in this scenario, you have one blood vessel coming through here and another blood vessel coming through here. So with an embolization, if I just blocked off this blood vessel, well, that might be great and I might give myself a pat on the back, but the PAVM is still there and it's still getting blood, so I haven't really treated the problem. So I need to know prior to the procedure and during the procedure how many blood vessels are going to the PAVM, and I need to make sure that once I'm finished the procedure that is completely treated. So in terms of workups, I just go through this quickly because I spoke about it a little bit already. But patients who come to the HHT Centre will usually have a bubble contrast echocardiogram. So what that really is, it's an ultrasound of the heart and we inject bubbles through the veins. So if in somebody without a PAVM, if I inject bubbles into the vein while I'm doing an ultrasound, I would expect the bubbles, I wouldn't expect to see the bubbles on the ultrasounds coming back into the opposite side of the heart. But in a patient with a PAVM, because of the abnormal vascular network, the bubbles will come straight through the AVM and come back out the other side. I'll see the bubbles coming through, and that's an indicator to me that there's probably a PAVM that the patient has. And if that's the case, the patient would be recommended to have a CT thorax. So CT thorax is usually a straightforward procedure, but we don't want to give it to every patient because there is some radiation that's associated with it, although that's becoming less and less with newer machines. And the outcome of having a chest CT would be that, number one, the patient doesn't have a PAVM, or at least doesn't have a PAVM that we can appreciate on CT, that they have a very small PAVM with a feeding artery that's less than 2.5 millimeters, or they have a PAVM with a feeding artery that's more than 2.5 millimeters. And if your PAVM is more than 2.5 millimeters, then we usually recommend the patients to have a pulmonary angiogram and an embolization. And as Kira alluded to and spoke better about it than I can, patients who have HHT or who have a positive echocardiogram should have antibiotic prophylaxis, particularly for dental procedures. If we do a CT study in a patient with a positive contrast echocardiogram, what we should do, if we do the echocardiogram is positive, but the chest CT doesn't demonstrate a PAVM, then we normally recommend that a patient has a follow-up scan every 5 years. Sometimes that can be difficult for the patient because you might be going home or wondering, is my PAVM getting bigger? And, am I walking around with a big risk factor? And of course, that's a natural feeling for someone to have. And those guidelines are based on, large retrospective studies. So we could CT scan somebody every 6 months, but we know from the studies that there's no benefit in that. And we know from further studies that we're probably conferring risk to the patient by overscanning them. And there's also, the logistical things of having to have a scan every 6 months. If you don't need it, there's no point having it. So in terms of intervention, prior to 1980, and really I suppose prior to the 1990s and 2000s, if someone had a PAVM, the only real management was either you do nothing and hope nothing bad happens, or you have a surgery. So I suppose the issue with the surgery is surgery has become, I suppose, particularly thoracic surgery has become, I suppose, more and more minimally invasive. But when somebody's taking out a PAVM surgically, they usually take out a reasonable volume of lung around it. So this is a patient with an abnormal chest X-ray, an abnormal CT scan, who's had a pulmonary resection, and you can see the PAVM here in the middle of the resected lung. But you do have lots of this lung isn't really normal, but you do have lots of relatively normal lung that's taken with it. So you can imagine if you needed to have 4 or 5 PAVMs taken out, you wouldn't have a lot of normal lung left. So embolization has been around since 1977, when the first, I suppose, reported case reports, and I suppose it's become more and more common and more frequently available in different hospitals. And the advantage of embolization is, number one, it's obviously a lot less invasive than having a surgical procedure, and number two, we can preserve much more normal lung than is possible with surgery. So this is a patient who's had a PAVM embolization, and I'll talk about this case a little bit later on. Well, I've touched on this slightly, but I suppose the predominant reason that we really perform PAVM embolization is to prevent stroke. So as I said, this is the blood that's coming from the heart to the lungs. And if you did get a blood clot that came from the veins through the lungs, it wouldn't be filtered by the normally capillary network. And this blood clot traveled back into the body. Once it comes to the heart, it can go anywhere. But obviously the concern is that it would go to the brain. And if that blood clot went to a portion of the brain, then the patient could present with a stroke. And it's a similar thing with, I suppose, bacteria, where the bacteria can travel straight through. And if the bacteria end up traveling through the blood vessels into the brain, then they can cause a brain abscess. So prevention of stroke and prevention of bacterial infection. Now, embolization doesn't completely eradicate the risk of bacterial embolization because bacteria are much smaller than clots, but I suppose it helps to reduce the risk. I'm sure some patients will have personal experience of embolization, but how do we perform it? We perform it in the radiology department using X-ray guidance. So we'll basically access a vein in the groin. We'll insert small catheters and wires into the blood vessels in the pelvis, back up through the body, into the right side of the heart. So patients who have had an embolization might remember that at some point during the procedure, they felt a real flutter in their heart. And that's when the catheter is traveling through the heart and out into the pulmonary artery. And once we get into the pulmonary artery, then we're able to use these small catheters to inject X-ray dye. So this is a catheter that's in the left main pulmonary artery, and we're injecting X-ray dye, and we can see a really large PAVM being opacified by the contrast. So what we'll do then is we'll advance a smaller catheter through this, I suppose, base catheter into this vessel. And then we have a number of options for what we can use to embolize. So this is basically an Amplatzer plug, which is really like, if you open it, it's like a sieve that you'd have for your dinner, that you'd use for making your dinner. But the space between the sieve is tiny, and it basically creates small blood clots within this area that blocks off the blood supply. And you can see here that this large PAVM that we could see prior to the embolization, no blood is getting beyond this. So any of the blood that's now coming into the lungs is going to the normal parts of the lungs and not going through the PAVMs anymore. So again, the options for embolization, we have Amplatzer plugs, which I showed you on the last slide. And then these look a bit like a slinky, but they're coils. So they're really, I suppose, some of these coils, they're like liquid metal. So it's almost like they're metallic, but they're like spaghetti. So once you push them through the catheter, they start curling back up on themselves, and they form a really tight mesh of coil that then stops the blood getting beyond it. Some coils have fibers on it. These fibers help to, I suppose, stop the blood supply a little bit quicker than the non-fibered coils. But sometimes that's just the companies telling us that one thing is faster than the other, when actually they're just trying to charge more for the products, really. And this is what it looks like when you're pushing them out. So we don't see into the vessel like this, but we're looking at it under X-ray guidance. So it basically forms like a big glob of spaghetti that that prevents the blood getting beyond us into the PAVM. Again, that's the same picture I showed you before. And this is coils inserted, and you can't see any blood getting beyond them. And there's different types of coils because everybody's PAVM can be a different size. And what do we expect to happen after embolization? Well, I suppose what we want to see, and usually we'll do a repeat CT scan. It depends on the patient, but sometimes after 6 months after the procedure. After we've embolized this, we'll inject X-ray dye again, and we want to see at the end of the procedure that any PAVMs that we could see at the start of the procedure are completely gone. But then we'll do a CT scan in 6 months, and what we want to see, this is the patient's heart here. This is the left lung with the large PAVM prior to embolization, and this is the CT 6 months after embolization, where you can see that this large PAVM has now scarred down to almost nothing. So we're happy that the risk that the patient had prior to the embolization is now reduced by blocking off the blood supply through that PAVM. It also means that any blood that's coming from the body going through the lungs is oxygenated normally, so patients shouldn't have their symptoms of breathlessness, and hopefully if they had symptoms of migraine prior to the procedure, that they should be reduced after the procedure. So as I said, this probably isn't something that we know that only 30% of PAVM patients or HHT patients will have a PAVM, and not all those patients will need embolization. So it's not something that's relevant to every HHT patient, but I suppose it's useful for every HHT patient to know why we're screening and why we're doing these workups, and what we do if we can actually, if we do identify these. So as I said, this is a multidisciplinary thing, so I might not be able to answer all your questions, but I'm happy to take any questions that you might have.
That's great. Thanks a million, Stephen. That's a great presentation. Thanks. So same as before, Michael, will you be able to cover off any questions that were mentioned in the chat box, and then we can see if we can open to the floor and see if there's any other questions.
Perfect. Okay. Again, Dr. Barr, thank you very much. That was very interesting. Couple of questions about the centre in Cork. How do I make an appointment for screening at the HHT Centre in Cork?
So I think all the appointments go through Dr. Brady's wife, Margaret, and there is an email address that Margaret checks up on. So I'd have to send that on to Dara, but I don't actually know the email address off the top of my head. But it's true. Margaret has an email address, and you can contact her.
Yeah, and she's Margaret Murphy HHT @gmail.com. Okay. Okay,
thanks, Dara. Do I need a referral from my GP?
I believe so, but again, I think my main role in the HHT Centre is performing these procedures. So oftentimes I see the patients after they've had their assessment and their workup. So I don't spend a lot of time actually vetting the referrals. So I think Dara or Margaret might be better positioned to let you know about that.
Perfect.
Margaret.
Is there only one place to go for screening for HHT in Ireland?
Well, I think, you know, as I said, HHT is multidisciplinary, but if I had a HHT or had a family member who had HHT, I'd want them to be managed and screened in a national centre where there's experience there of patients going through them. I mean, you know, no matter what doctor you go to, they're not going to see hundreds of HHT patients every month, you know, because there just isn't that volume there. So I would prefer, you know, I would advise anyone to go to a national centre, which, you know, sometimes obviously I'm obviously biased. I think Cork is great, but I know it's a bit cumbersome for patients who are like, you know, who are more northern or who are higher up the country to come down to Cork. But I do think that for a condition that's a rare condition that most doctors and most hospitals won't see. I mean, as I said, CUH is one of the biggest hospitals in the country. I think since I've been here for the last 2 years, I've never seen a PAVM. So, you know, most hospitals that you go to, the doctors won't have any experience. And in a lot of cases with these rare disorders, oftentimes the patients will actually know more than the doctors about the correct treatment and the correct management. So that's why I probably would recommend people to go to a HHT centre where they have regular experience of seeing these patients.
Okay, we're very appreciative of Cork, to be honest. A lot of us have been there and it's great to have it. Another question, are we born with PAVMs from birth or can they develop midlife?
They usually develop like during a patient's life. So I suppose we don't really screen like babies or young children for PAVMs because a lot of times their heart hasn't matured fully. So the ultrasound, you could think that there's a PAVM there, but actually you could be overcalling it on the ultrasound. So usually they develop during a patient's life. And that's why we screen patients. If we do a screening study and the patient doesn't have a PAVM, we do a CT scan at 5 years because we know that patients, they can grow. Oftentimes they're stable, but they can grow or they can develop during a patient's life. So typically they progress during a patient's life. And I suppose the typical times for them to grow are during adolescence or during pregnancy.
Okay. And in the case of having, say, small PAVMs, should you wait 5 years or is 5 years a long time?
It seems like a long time. And, you know, for the individual patient, obviously that's very stressful. And I suppose you can never say for the individual person, like, you know, if someone comes to me after 3 years and say, can you guarantee that my PAVM hasn't grown? I can't, you know, but the 5 year wait time is basically is based on clinical research where we looked at hundreds of patients with HHT, looked at the typical rate of growth over a period, and identified how quickly they usually grow. And that's, I suppose, the recommended international guidelines for how quickly you'd be followed up. But that's much easier for, you know, for someone who doesn't have HHT. It's much easier for me to say you should wait 5 years than a patient who has a PAVM who's wondering, is it growing? But what I can reassure people is that's what the guidelines would suggest are the typical rates of growth, that it doesn't usually grow, you know, it doesn't grow within 6 months that would require any change in your management.
Okay. And is there a standardized care plan for children of HHT patients, and does it differ from adults?
I suppose like a lot of patients will be in their adolescence, and you know, my experience typically in Ireland has been with adult patients. So I mean, I've dealt with adolescents, so kind of 12 to 14 or 12 to 18, but I don't have a lot of experience in dealing with patients younger than that. So I can't really speak to the typical screening strategy for you know, pediatric patients.
Okay. And the next question is, Dr. Power mentioned embolization for epistaxis. How common is this procedure and what severity of bleeding is it carried out for?
Obviously epistaxis is common, you know, patients with HHT and without HHT, you know, it's like, it's not uncommon for patients to get a nosebleed, but obviously 90% of patients with HHT have a nosebleed. Typically, so in interventional radiology, there's basically two subspecialties. The first is neurointerventional radiology, and then the second is general interventional radiology. Typically, anything above the neck is managed by neurointerventional radiology, and anything below the neck is managed by general interventional radiology. So most of the referrals for epistaxis embolization are through ENT surgeons or through ENT hospitals. And then they would usually refer patients to either the neurointerventional radiologists here in Cork, there's 3 of them, or the neurointerventional radiology department in Beaumont in Dublin, and there's 5 or 6 neurointerventional radiologists there. So it's an uncommon procedure. I suppose embolization procedures for neurointerventional radiologists are a very common procedure. Epistaxis embolization isn't common, but the service is available in Cork and Beaumont. But you would only do this procedure for patients who are having really severe bleeding that can't be controlled by conservative measures, because even within the nose, there can be small, you know, arterial communications with the eyes and within the brain. So you really want it done in specialist centers, and you only want to do it in patients that really need it because, you know, there are risks that are associated with it. So the service is available, but from my experience working here, you know, it's very limited times that actually patients actually need to have the procedure done. In Toronto, again, I would have had experience of being involved in procedures there. And again, it's a procedure that's provided, but it's uncommon for patients to actually need to have it done.
So embolization of the nose is very rare?
Yeah.
And is it normally done after failed laser therapy, or?
Well, probably this would be done for like really severe bleeding. So it would be like profuse bleeding that can't be managed. And usually, say if the patient came to ear, nose, and throat, they would have packing procedures. Yeah. And if that didn't work, it would usually be in a patient who's, Dr. Keane spoke earlier about patients with hemodynamic instability. So if we were worried that a patient was bleeding so much that it might actually be, life-threatening for them, those are the patients that typically have epistaxis embolization. And most other patients, it's not something that we kind of do prophylactically because a patient has had, 5 or 6 nosebleeds. It's something that we do when there's a life-threatening, it's life-threatening for the patient, really.
And is it successful? Is it something that takes and lasts, or? So
it's successful usually in stopping it.
Yeah.
But there's situations where you'll do the embolization procedure, you'll have an image like I showed you in the last where you've gotten rid of all the vascular blood supply. The patient will leave the interventional room and then they'll start bleeding in the hole. So it can be successful and it can stop the bleeding, but it's not something that's, just because you've had an epistaxis embolization, that's not going to cure your epistaxis. It will come back. It's just to prevent, I suppose, it's really, I suppose, if there's a life-threatening bleed, to stop that at the time.
Okay. Obviously, we can have multiple epistaxis, so the embolization of epistaxis doesn't mean you're not going to have other epistaxis.
Yeah, that's true. Yeah.
Is the embolization, the ones that are actually embolized, are they normally successful?
They're normally successful, but usually so basically a PAVM, when we embolize those are really well-formed vascular malformations, where an epistaxis is more like a telangiectasia, where there's really multiple small friable blood vessels on the nose. So you can block off some of those blood vessels, but then over time, more of those blood vessels will come back. So you may have an embolization and you might not have a nosebleed for 3 to 6 months. You may have one the week after. It may not be as severe as the nosebleed that you had that required you to have the embolization, or in some cases you may have another nosebleed that needs an embolization down the line. So it's, as I said, it's not HHT isn't common, but epistaxis embolization in HHT is even less common than that.
Okay. And in the terms of the coils that you were showing us earlier, do they migrate? Do they move over time?
So that's one of the real concerns during the procedures, and that's why, if you have say a 5 millimeter feeding vessel to a PAVM, you would usually put in like an 8 millimeter coil. So you would oversize the coils to try to make it form within the vessel. So there's a very small risk of coil migration. It's probably in the range of 1 to 3% during a procedure, but there are ways that you can retrieve the coil. Now, typically, if you've had an embolization and there isn't a coil migration at the end of a procedure, I've never seen a coil migrating after that, because the vessel that you put the coil into will scar down. It'll basically close around the coil, and then it's almost, I've never seen a situation where a coil has embolized after a procedure. So you don't need to worry like 6 months later that a coil has moved somewhere else. If it's going to embolize, it'll embolize at the time of the procedure.
Perfect. Okay. And in terms of the so the lung embolization, you're using the coils, and in the embolization of the nose, that's a different procedure? Is that? So
usually with the nose, because they're very small, there's very small blood vessels, and basically what we call them are end blood vessels. So the blood vessels we're accessing are just going to the mucosa of the nose. We can use very small plastic particles. Whereas if we used plastic particles in a lung embolization, they would basically travel through the PAVM and they'd actually probably cause a stroke, So it's there's lots of different ways that we can embolize things. And I suppose, as I said, we use embolic materials for lots of different procedures. So we just choose the right one for the right procedure. So, lots of people would just use coils. Some people just use plugs. Some people might use coils for epistaxis, but typically it's small plastic particles we use for nose embolization. Okay. This recording is fantastic because we're asking questions here that people will be able to listen to at a later date. So hopefully a lot of people will actually get the recording. I'm wondering, out of curiosity, how many people are you seeing in Cork
I mean,
for AVM embolization?
Yeah, well, HHT patients particularly, yeah.
Well, I suppose again, my role is predominantly in the PAVM embolization, and like I suppose annual numbers can be variable. But since 2003, there's been 202 embolization procedures, so it's probably ranging about one a month, something around that level. How many embolization procedures do we see in radiology or interventional radiology? We probably see 3 to 4 every week. So it's not that sometimes when you say, well, you're only doing one a month, how can you have any experience in actually dealing with these? It's more actually the skills that you learn using the other embolization procedures allow you to perform the PAVM embolizations safely.
You know, I was thinking more of obviously Cork came on the scene a number of years ago, and a lot of people with HHT who were aware that they had HHT traveled to Cork, and it was fantastic to do so. But I'm sort of wondering, are the people who are in the know, have they already been, or are you finding that you still got people coming to Cork on a fairly steady basis presenting with HHT?
Again, I think Margaret would probably be better able to answer that for you, because again, most of the patients I see have been through the screening procedure and they've had the PAVMs. So on a day-to-day basis, my day-to-day work is in CUH in Cork University Hospital. So I don't actually see a lot of patients that are within the clinic or that are seeing Professor O'Connor. But from my understanding, there is a steady stream of referrals that come through. Okay,
interesting. And the last question I think I have here is embolization versus dermoplasty, skin graft. Is that something that gets done?
So I suppose, again, this is, as I said, HHT is a multidisciplinary thing. There are like superficial embolizations that you can do. We don't do those here in Cork, so I can't really speak on the efficacy of either one of those, really.
Okay. Look, really enjoyed the presentation. Thank you very much for taking all the questions. And unless, Dara, if you've got another one, that's been really, really useful. I'm sort of wondering, funny enough, when I see that the three of you are still here, before you go, I'm wondering whether you or Ciara or Niamh have picked up anything, because I think you indicated maybe from listening to Ciara that you picked up something. Is there something that you guys learned about HHT because of this coming together?
Yeah, well, I certainly learned a lot that I didn't know before.
Excellent. Okay.
I also didn't know that bananas had a lot of sugar in them, so I need to.
Well, I was delighted to see that cider is a lot better for you than a lot of other drinks, so that was good news. But yeah, the cubes of sugar was a bit scary, but anyway, look, thank you very much. If anybody else has any questions, let us know. Otherwise, thank you very much, Dr. Barron.
Thanks very much.